Good afternoon. My name is Janie Gordon, and I'm with the Mid-Atlantic Public Health Training Center, and I would like to welcome everyone in our live audience and our online audience to today's presentation. Today is a special grand rounds that we're doing in conjunction with a number of partners, and I will let Barbara Conrad give you more information about that. Before I turn the microphone over to Barbara, who's chief of the Center of STI Prevention at DHMH, I just have a few quick announcements. For people who are watching online, check out our website to find out about other archive grand rounds and also available online and face-to-face trainings. And our next grand rounds will be on May 21st, and we'll bring a public health lens to youth sports. For those watching online, you can email a question anytime during the presentation by simply clicking on the link. And with that, I'm going to turn the microphone over to Barbara Conrad.
Welcome, and thank you for joining us today. This is the 5th annual Sexual and Reproductive Health webinar, a joint initiative of the Center for STI Prevention at the Maryland Department of Health and Mental Hygiene, the STD/HIV Prevention Training Center, and the Mid-Atlantic Public Health Training Center at the Johns Hopkins Bloomberg School of Public Health. The focus for this April's National STD Awareness Month is STI prevention as HIV prevention. In keeping with that theme, today's webinar is on the intersection of clinical and public health practice, STI management in the HIV-infected person. Our presenter today is Dr. Khalil Ghanem. Dr. Ghanem is an associate professor of medicine in the Infectious Diseases Division at the Johns Hopkins University School of Medicine and holds a joint appointment in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. He is also the Deputy Director of Education in the Department of Medicine at the Johns Hopkins Bayview Medical Center. He is board certified in internal medicine and adult infectious diseases. Dr. Ghanem has received multiple honors and teaching awards. He has authored over 50 journal articles on STIs and HIV and has contributed 11 book chapters on sexually transmitted infections. He is an associate editor of the journal Sexually Transmitted Infections and is a consultant to the Centers for Disease Control and Prevention on the development of the 2014 STD treatment guidelines. It is my pleasure to introduce Dr. Khalil Ghanem.
Thank you, Barbara. It's a pleasure to be here. Today, we're going to be talking about the intersection of clinical and public health practice, STI management in the HIV-infected person. Let me start by apologizing. I'm getting over a cough, so hopefully my voice will survive the 1-hour talk. A few comments right before we start. Remember, either click for any questions you might have, or you can email your questions for me at the following email that I'm showing you right now. I have no disclosures regarding this talk, and I will be speaking about some off-label uses, particularly nucleic acid amplification tests for extragenital gonorrhea, chlamydia, and trichomoniasis, genital trichomoniasis testing in men. And I will highlight that when I talk about it. And I'm going to start off by mentioning that I've structured this talk essentially to take off from the new primary care guidelines for the management of persons infected with HIV that were just recently released about a month and a half ago. And so the cases surrounding this talk and the information is mainly derived from the recommendations within this new document. And it's freely available to you on the Infectious Diseases Society of America website, as well as the Clinical Infectious Diseases website. So these are our objectives for today: to recognize the critical components of the history and physical examination of HIV-infected patients that impact STI screening and management, to describe recommended approaches to screen for syphilis, gonorrhea, chlamydia, trichomoniasis, and herpes, to identify appropriate antimicrobial treatment regimens for gonorrhea and formulate an approach to preventing HPV infections among HIV-infected persons. So by the end of this talk, hopefully you'll be able to answer all of these questions. So let's start with a case. A 30-year-old man who was recently diagnosed with HIV, a CD4 count of 650 cells, and 55,000 HIV RNA, presents for his first clinic appointment. He's completely asymptomatic, feels well, doing very well. Which of the following screening tests should be performed at initiation of care, and how often should the screening test be repeated thereafter? Should you get nucleic acid amplification tests for rectal chlamydia at initiation and every year thereafter? Should you get NAT for pharyngeal gonorrhea at initiation and yearly thereafter? Should you do a serological screening for syphilis at initiation and yearly thereafter? All of the above are correct, or none of the above are correct. So I'll give you 1 second to figure out what you want to say, and I'm going to give you the answer. And the answer is, of course, it's none of the above. And hopefully by the end of this section, you'll understand why it's none of the above. But the main reason why is because we don't have enough information to make that decision based on the question that I gave you. And so let me start by reminding you that the majority of sexually transmitted infections are asymptomatic. Up to 70% of herpes infections are asymptomatic. A majority of chlamydia infections in both men and women are asymptomatic. 75% of trichomoniasis infections in both men and women are asymptomatic. So if you're asking about symptoms, you are missing the majority of cases of sexually transmitted infections. But you have to remember that appropriate screening and appropriate intervention requires the knowledge of risk. You have to know risk before you can decide what you need to do with a patient. And so the risk assessment is critical. And the only way to assess risk is to ask questions. And the way you ask questions is also critical. There's one thing I learned over the last 15 years of my doing this. Patients don't want to lie to you. But patients actually want to tell you what they think you want to hear. And so because of that, the way you ask a question to assess for risk is critical. So one potential way of asking a question to a patient is, do you have oral sex? Do you use a condom when you have oral sex? That may not be the best way of doing it. There are different ways that would allow you and allow that patient to give you an answer that they think you may not want to hear. And so by asking it in a slightly different way, you're giving them permission. You're telling them it's okay if you are having it. Just give me the information that I need. So an alternate way of asking this question is, the last time you put your mouth on your partner's penis, did you use a condom? Do you use a condom most times you do that? If they say yes, I use the condoms most time I do that, you know they don't use the condoms every time they do that. So you've been able to get that information without shutting the patient down and without making the patient tell you something that they think you want to hear, which turns out to be not the truth. So asking the questions and the way you ask the question is critical. And knowing what the behaviors the patient is participating in is critical to know when and where to screen the patients for sexually transmitted infections. So that's the most important thing to take out from this section. And so let's talk a little bit about screening. We're going to talk about screening for chlamydia, gonorrhea, trichomoniasis, syphilis, and herpes. Let's first start with chlamydia and gonorrhea. The best specimen type to screen for gonorrhea and chlamydia, if you're using nucleic acid amplification tests, in women, it's been found that the best specimen type is a vaginal swab, and that can be a vaginal swab that the woman collects or that the clinician collects. Endocervical swabs and urine are acceptable alternate specimens for NATS testing in women. If you're doing a gonorrhea culture, however, the only acceptable specimen is an endocervical swab. You can't send urine and you can't send a vaginal swab in women. For men, the best specimen to send for gonorrhea and chlamydia testing of the urethra is a urine specimen. Remember, this is a first catch urine and not a midstream urine that we normally send for a urinalysis. Urethral swabs are acceptable for nucleic acid amplification testing as well. If you're doing gonorrhea culture, a urethral swab is the best and only specimen you can obtain. Urine is not acceptable. So in women, for gnats, the best specimen is vaginal swab, and in men, it's first catch urine. The question comes up, is genital screening alone enough, or should we be screening other sites of exposure? Remember, you've asked the right questions. Now you know that the patient has had genital exposures, but also perhaps extragenital exposures, the throat and the rectum. Remember that up to 90% of cases of gonorrhea and chlamydia in the throat and rectum are asymptomatic. Again, if you're asking about symptoms, you're going to miss the majority. What's also interesting, and particularly among men who have sex with men, if you only do genital testing for gonorrhea and chlamydia, you might miss the majority of cases. A lot of cases of gonorrhea and chlamydia are found in the rectum and in the throats, particularly of men who have sex with men. In women, you would miss about 30% of gonorrhea cases and about 10% of chlamydia cases if you only did genital testing. However, the proportion of cases tends to be much lower in women than in MSM. MSM have some of the highest rates of gonorrhea and chlamydia, as well as some of the highest rates of extragenital gonorrhea and chlamydia. And remember now that testing for extragenital gonorrhea and chlamydia in MSM is a quality measure from HRSA. So you really should be doing that, particularly in MSM. We'll talk a little bit more about women. And rectal and pharyngeal infections are of public health significance. They can be transmitted to the partner's genital tract, and from there, the other partner can transmit them to his other or her other partners. So they are of public health significance. The other reason why pharyngeal gonorrhea is important is because it's thought that resistance development tends to occur in gonorrhea that's colonizing the pharynx. And so by treating it, we're trying to decrease the risk of antibiotic resistance developing in gonorrhea. It's also worth knowing that for gonorrhea, culture in the genital tract is actually quite sensitive and very specific. The problem is that culture is not very sensitive to detect extragenital cases of gonorrhea. If that's the only diagnostic modality you have, then by all means use it. But understand that several recent studies suggest that the sensitivity of culture for pharyngeal and rectal gonorrhea is far less than nucleic acid amplification tests. And that's why the CDC currently recommends that you use nucleic acid amplification tests to look for gonorrhea and chlamydia in the rectum and gonorrhea in the throat. It's worth noting that the CDC currently does not recommend routine screening for chlamydia in the throat because it is thought that the prevalence is low. So in the throat, you're looking for gonorrhea. In the rectum, you're looking for both gonorrhea and chlamydia. And preferably, you're using nucleic acid amplification tests because they have a much higher sensitivity than culture. The other thing to keep in mind is that the FDA has not cleared any nucleic acid amplification tests for extragenital testing. But remember, you don't need FDA clearance to be able to run a test. As long as the lab has done an in-house validation assay to show that their test is sensitive and specific, they can perform this test and they can bill for it as well. Be aware that the majority of moderate and large commercial laboratories are routinely offering nucleic acid amplification testing for extragenital sites. So that really should be what you do in your patients if you have access to it. Here are the GC and CT screening recommendations. It's a horrendous slide, but I tried to include everything on one slide because most people say it's never found on the same slide. And I'm going to try to give you the highlights of these recommendations. So remember, with chlamydia in women, the recommendation is all sexually active women who are 25 years or younger should be screened annually for chlamydia in the genital tract. All high-risk women who are older than 25 should also be screened annually. And high-risk women are women who've had new multiple sex partners, recent sexually transmitted infection, commercial sex workers, etc. Annual screening for gonorrhea is recommended for all sexually active MSM, and targeted screening is recommended for high-risk women. And I've listed the risk factors for that on the slide. Extragenital screening is recommended for MSM particularly, but it's also suggested in women who are HIV infected if they report extragenital exposures. Remember, for gonorrhea, you can test both the oropharynx and the rectum. For chlamydia, it's mainly the rectum. The frequency of screening depends on the level of risk, and that's where we come back to the initial question that I asked. Depending on the level of risk for that patient, you may be only screening once a year, but if they're high risk, if they're having multiple sex partners, if you're detecting STIs every time they come in, then the screening frequency may be more frequent than every year. It could be every 6 months, and in some cases, it could even be every 3 months. And that's precisely why it's important to get an assessment of risk, because the risk assessment will allow you to determine how frequently to screen these patients for STIs. I didn't mention this, but I'm going to go back and mention it, that for sexually active MSM, there are also recommendations to screen annually for chlamydia as well. So the recommendations for screening for gonorrhea and chlamydia are summarized on the slide. Screening for trichomoniasis. This is something that people tend to forget, and it is a recommendation. You must screen all your HIV-infected women for trichomoniasis annually. And what's really interesting about trichomoniasis is that the prevalence compared to other STIs tends to increase with increasing age. Most other STIs, the prevalence tends to decrease with increasing age, but not trichomoniasis. So there is a recommendation. All sexually active women who are HIV infected should be screened for gonorrhea on an annual basis. There are no formal screening guidelines for men at this time. But remember, the majority of men and women who have trichomoniasis are asymptomatic. And also remember that any patient who's diagnosed with trichomoniasis, just like with gonorrhea and chlamydia, their partners have to be treated. All the sex partners that they've had in the preceding 60 days or 2 months need to be treated for either gonorrhea, chlamydia, or trichomoniasis. So partner therapy is essential for trichomoniasis. How do you diagnose trichomoniasis? In symptomatic women, in women who come in with a discharge, complaining of a discharge, a wet mount has a sensitivity of 70%. So remember, you might miss 30% of women who are symptomatic who have trichomoniasis if you're only doing a wet mount. And remember that you have to do the wet mount quickly. Once you get the specimen, within 10 minutes, you have to read it. Otherwise, the sensitivity decreases significantly. The good thing about the wet mount is that it's cheap. Culture is available for testing trichomoniasis in both men and women, and it can be done. The downside with culture is that it takes about 3 days to get the results back. There's a rapid antigen test, which is somewhat better than wet mount and can be done in clinics, but remember, it's not 100% sensitive. By far, the best diagnostic modality is the nucleic acid amplification test. So just like gonorrhea and chlamydia, trichomoniasis, there was a nucleic acid amplification test that was FDA cleared to screen women for trichomoniasis, and you can use either vaginal swabs or you can use urine to detect trichomonas using these specimens. And like I said before, many labs are offering nucleic acid amplification testing for trichomoniasis also for your male patients, even though it's not FDA cleared for that indication. So again, the best test for trichomoniasis is PCR, but there's certainly a cost issue. And so if your patient is symptomatic, if you don't have access to these tests, then your best option is probably with the wet mount, but you should understand the limitations of the wet mount. And if it comes back negative, you haven't entirely ruled out the possibility of trichomoniasis. Also remember one very important thing. When you make a diagnosis in your patient of gonorrhea or chlamydia or trichomoniasis, you have to, and once you treat them, you have to bring them back and screen them in 3 months because they're at very high risk of getting reinfected. And you have to bring them back and rescreen them even if their partners were treated. In most studies that have been done, the prevalence of infections in these patients at 3 months can be as high as 25%. So bring them back and retest them 3 months after you treat them, even if their partners were treated. So we've talked about gonorrhea, chlamydia, and trichomoniasis. So now let's talk about screening for syphilis. I want to remind you of a couple of things because this has caused a lot of confusion now that there's a new diagnostic algorithm for syphilis. So let's talk a few basic approaches. Let's first focus on the antibody tests. There are 2 different types of antibodies for syphilis. The first type are the non-treponemal or non-specific antibodies. And the ones that we use in this country most often are the RPR and the VDRL. The RPR is mainly used for serum, and the VDRL is mainly used for CSF, although you can also use the VDRL in serum. They're not interchangeable, so you can't use one or the other when you're looking at them in serum. Choose one and follow the patient with that. These non-treponemal tests are less specific than treponemal tests, but they're very useful because they're the only antibody tests that you can follow to look at a patient's response to therapy. So you get titers with these tests. So you'll get an RPR, and the RPR will come back as either positive or non-reactive, and if it's positive, the lab will give you a titer. And looking at that titer will allow you to determine whether a patient is responding to therapy or whether a patient has relapsed or been reinfected. Classically, a 4-fold decline in RPR titers means a cure, and a 4-fold increase in titers usually means either a reinfection or a relapse. Those are the non-treponemal titers. The other thing to remember, the final thing to remember with these non-treponemal titers, is that with treatment, these titers can become negative. But also remember, this is very important to keep in mind, that even without treatment, over time, these titers can also become negative. So keep that in mind when we talk about the algorithm. The other tests that are available are treponemal tests. And there are many different treponemal tests. There's the EIA, the CIA, the FTA, the MHATP, the TPPA, a whole bunch of them. So if it's not an RPR or a VDRL, and they tell you it's a syphilis test, it's most likely a treponemal test. Treponemal tests, once positive, always positive. They're not useful to follow response to therapy or to determine if somebody who had syphilis in the past has been reinfected. Again, usually, for all practical purposes here, once positive, always positive. That's why you need the RPR test to help you determine what you're doing with your patient. So now that we've covered the 2 basic tests for syphilis screening, let's talk about how we screen for syphilis. Everybody's familiar with the traditional algorithm. You start with the RPR. If the RPR is negative, then the patient either has early syphilis, because they haven't had time to develop antibodies yet, and that's why a good physical exam and a good history is critical. And if the RPR is negative, it can either be very early syphilis, which is rare, or the patient doesn't have syphilis. If the RPR is positive, then the lab automatically gets a treponemal test. If the treponemal test is positive, then you assess the patient and you stage them and you treat them based on stage. If the treponemal test is negative and the risk for syphilis is relatively low, then most likely that positive RPR is a false positive and the patient does not have syphilis. So everybody knows how to interpret this classic or traditional algorithm. People get confused with the new reverse sequence algorithm. The reason why this reverse sequence algorithm has become very popular is because it's cheaper for the labs to do. They're starting off with a treponemal test. And usually it's either an EIA or a CIA. And those tests are automated. You can run thousands of specimens in a matter of hours as compared to the RPR, which requires manual performance. And so that takes a much longer time and it costs much more money to start with the RPR usually. So a lot of the large labs have moved to this reverse sequence algorithm. So let's go through this reverse sequence algorithm and essentially tell you how to interpret the results. So usually the first test is a treponemal test, and it can be either a CIA or an EIA. Assuming that it comes back negative, then the patient most likely doesn't have syphilis, or they could have very early syphilis, just like with the RPR. You need to get a good history and physical exam. Let's assume the CIA comes back positive. The lab will automatically do an RPR. If the RPR is positive, then you do exactly what you did with the traditional algorithm. You stage the patient and you treat them according to the stage that they're in. On the other hand, if the CIA is positive, but if the RPR comes back negative, the lab will automatically do another different treponemal test to confirm the initial positive CIA. The other treponemal test is actually positive, then there are several possibilities. Now you have two positive treponemal tests and a negative RPR. The possibilities are the patient has old treated syphilis, the patient has old untreated syphilis of very long duration, or perhaps in rare cases, the patient could have early syphilis and the treponemal tests became positive before the RPR. So those are the three main possibilities. Again, you have to go back to the patient, ask them about their past history. So if the patient says, yeah, I was treated for syphilis 10 years ago, most likely there's nothing more to do. It's old treated syphilis. On the other hand, if the patient says, no, I was never told I had syphilis, and you do a good physical exam and you don't find any evidence of early syphilis, then perhaps the patient has old untreated syphilis. One good way to find out is to call your local health department, find out if they have any data about your patient, and if they have no data on your patient, the next step is to do a good physical exam, make sure they don't have neurological signs or symptoms, and if they don't have neurological signs or symptoms, then you can treat them as if they had latent syphilis. It would be syphilis of unknown duration, and you would use 3 weekly doses of 2.4 million units of benzathine penicillin. So that's how you interpret the reverse sequence algorithm. It's very straightforward, and it gives you the same information of the original algorithm. Excuse me. Let's talk a little bit about syphilis. Syphilis in Baltimore City, as in Maryland altogether, as well as in most major cities. There has been a change in the epidemiology over the last 10 to 12 years. Most cases of syphilis now are occurring among MSM, and many of these MSM are HIV-infected. And so this raises a very important question and a very important issue, and that is frequent screening, particularly of MSM, for syphilis. It is critical that your sexually active MSM be screened frequently for syphilis, because about 80 to 90% of all infections, all early syphilis infections, are occurring in men. Most of them are MSM, and many of them are HIV-infected. What's also very critical to remember is that when you see a patient who has syphilis in your office, be aware that about 20 to 30% of these patients will be back with another infection, with another syphilis infection. They will get reinfected, just like with gonorrhea, chlamydia, and trichomoniasis. So it's important to screen to know whether a patient has been reinfected. And reinfections, when they do occur, can occur very shortly after treatment. In about 26% of those who got reinfected, they got reinfected within 6 to 12 months after treatment. And this is something important to remember, that once you treat syphilis with penicillin or the alternate agent doxycycline, patients now are susceptible to get syphilis again. So you've essentially not, getting one episode of syphilis and treating it does not provide protection for other subsequent episodes. And that's true for gonorrhea, chlamydia, trichomoniasis, syphilis, etc. There is no protection there. Again, syphilis is a huge problem among MSM, and it's a huge problem also, particularly also among HIV-infected MSM. So syphilis and HIV go hand in hand, and it is critical to screen frequently if the risk is there. And so, what is the cost and efficacy of screening? It's interesting to note that every 3-month screenings among sexually active MSM at high risk for infection is very high yield and cost efficient. Contact tracing is also very important, but it tends to cost more than frequent screening. We still do contact tracing, and it's very important to do, but it's also extremely important to screen your patients frequently. What's also very interesting is that mathematical models have suggested that changes in behaviors and condom use, particularly short-term ones, even long-term ones if they only have modest impact, would not impact syphilis rates, and that the one thing that could impact syphilis rates is actually frequent screening. So I think I've driven the point home. That's really important to screen, particularly your MSM patients and those who are HIV infected, who are sexually active, for syphilis. About 30% of high-risk MSM were not rescreened in the 6 months following therapy for syphilis. So what are the screening recommendations? Routine serological screening for syphilis is recommended, and here are the key words, at least annually, but much more frequently if your patient is higher risk. Again, the importance of risk assessment to determine the need for screening and the frequency for screening. What about herpes simplex virus? Well, the screening tests that we use, and whenever I say screening, remember, screening implies that the patient does not have any symptoms. You're doing the testing not based on symptoms, but based on risk. When I say testing, it usually means that you're testing based on patient symptoms. So screening tests for HSV implies that the patient doesn't have any symptoms, and so your screening tests that are available, the only screening tests, are serological tests, IgG antibodies to HSV1 and HSV2. Remember that both HSV1 and HSV2 can cause genital herpes, but you have to be careful how you interpret the serological tests. If the serological test comes back as positive for IgG2, that is, they're positive for HSV2, you can tell the patient that they have genital herpes. Herpes simplex type 2 mainly causes genital herpes. On the other hand, if the test comes back positive for type 1 antibodies, you don't know whether the patient has genital herpes or whether the patient has oral herpes. Remember, type 1 can cause oral cold sores as well as genital infections. And so if you're just doing screening and the patient doesn't have any symptoms, you probably only want to screen for type 2. You probably don't want to screen for type 1 because it's hard to interpret what type 1 means. If the patient has symptoms and you're testing, that's different. And so then you might be looking for both type 1 and type 2. Also remember, don't ever get IgM serologies to try to find out whether this is an early infection or not. IgM serologies do not tell you whether this is an early infection or not. They're not sensitive and they're not specific for early infections. So when you're using screening tests for herpes, it's serologies. But the big question is, should you be screening your patients for herpes? And the answer is, at this time, routine screening is not recommended. Because for many different reasons. One of the reasons is that there's no cure for herpes. Another reason is because we have limited data that tell us if you screen somebody and you tell them they have herpes, that it's going to decrease the risk of transmission to others. There are very limited data on that. And because of the cost of screening, it's not inconsequential. And so for now, routine screening is not recommended. But there are certain times when you would consider testing for HSV. For example, if a patient comes in and says, I have recurrent genital ulcers, I don't have any right now, what could be causing this? You can certainly screen them with serologies to try and tell the patient whether they are positive for herpes simplex virus. Another time to test a patient and screen a patient is if you have a monogamous couple that comes in and clinically one person appears to have genital herpes and clinically the other person doesn't have genital herpes. So for example, a couple comes in, they're married, they're monogamous. The wife says, I've never had any symptoms. The husband says, in the past, I had some genital ulcers, but now I don't have any symptoms. And they're worried that the husband could transmit the virus to the wife. So you would screen both of them. And the reason why is simple. If you took 100 couples where clinically they appear to be discordant, one is positive and the other isn't, one has genital herpes, the other one doesn't. If you test them, you will find out that in 25% of the cases, they will be seroconcordant. In other words, both are infected, and you don't need to put the one who's infected on suppressive antiviral therapy. So it makes a huge difference in that setting. So on this slide are several potential considerations for screening. And from the CDC guidelines, they say you might consider screening in persons presenting for an STD evaluation, persons who are HIV positive, and MSM. But that's only a consideration. It is not a formal screening guideline. The other thing you have to remember is that none of these screening tests, whether it's herpes, gonorrhea, chlamydia, trichomoniasis, none of these tests are 100% specific. I'm not aware of any single diagnostic test that's 100% specific. What that means is, if the suspicion is low, any positive test that you get is probably going to be a false positive. In other words, don't screen patients who are low risk for having that infection. And that applies to any diagnostic test. So keep that in mind. Only screen your patients who are at moderate or high risk. All right, so we go back to this case 1. If you go back to it and think about it, we don't know anything about this patient. We don't know the risks. He may need to be screened every 3 months, every 6 months, or every year for many different types of infections. So you need more information. You need to go back to that patient and ask him more questions to figure out what to screen him for and how frequently to screen him. Let's talk about management of certain infections. So here's another case. A 24-year-old HIV-infected woman presents with an endocervical discharge. The Gram stain reveals intracellular gram-negative diplococci. So now you know that she probably has gonorrhea. You sent a nucleic acid amplification test for both gonorrhea and chlamydia, and the patient is treated with single-dose oral cefixime and 1 gram of azithromycin. She's sent home, her partner is treated, but she comes back 1 week later with persistent symptoms. She denies any intervening sexual exposures. The NAT that you obtained a week earlier comes back, and it confirms the diagnosis of gonorrhea, but she didn't have chlamydia. You do a gram stain again at this visit, and it still demonstrates evidence of gonorrhea, despite treatment. In addition to obtaining a specimen for culture, what do the most current CDC STD treatment guidelines recommend for therapy? So what should you do in this patient? And so you can use azithromycin 2 grams. You can use a higher dose of cefixime with a gram of azithro. You can use 250 milligrams of ceftriaxone and a gram of azithro. You can use 250 milligrams of ceftriaxone and 2 grams of azithro. Or you could use ciprofloxacin. Which one do you want to use? You get a second. I know you all got the right answer. And there it is. So the CDC currently recommends that in the setting of treatment failure, when you've used an oral cephalosporin to treat gonorrhea, you should use ceftriaxone, 250 milligrams IM intramuscular, and 2 grams of azithromycin, not 1 gram of azithromycin. You would use 1 gram of azithromycin to treat incidental cases of gonorrhea, but if this is a relapse, if you suspect that this is treatment failure and not reinfection, you should use 2 grams of azithromycin to treat it. You should also obtain cultures to look for susceptibility testing, because in this case, it's possible that the patient has developed cefixime resistance. In Baltimore City, I know of 4 strains of gonorrhea with cefixime resistance that have been detected in the last year. However, in the US, we have not yet detected ceftriaxone resistance. And so ceftriaxone, and that's precisely why the CDC now only has ceftriaxone as the first-line agent to treat gonorrhea. So now when you're treating gonorrhea, even if you've excluded chlamydia trachomatis co-infection, so even if chlamydia is excluded, you have to use 2 drugs. The first drug is ceftriaxone, 250 milligrams IM, and the second drug is either azithromycin 1 gram orally or doxycycline 100 milligrams twice a day for a week. Azithromycin is preferred over doxycycline, but both are acceptable. That's the only first-line recommended therapy for gonorrhea. That's the only one. Alternates do include cefixime with either azithro or doxycycline, but you should only use the alternate if there is no other way to use first-line therapy. If your patient has a cephalosporin allergy, your only option is the alternate 2 grams of azithromycin as a single agent. Remember that in about 15 to 20% of your patients that you treat with 2 grams of azithromycin, they will have vomiting. And so you probably, if you're going to use this approach, you probably want to observe them for about an hour after you give them the antibiotic. Treatment failure with alternate regimens, again, requires that you use, if you get a patient who was started on an alternate regimen, either cefixime or 2 grams of azithromycin, what you need to do is treat them, treat their partners, and bring them back in a week to 2 weeks for a test of cure. That's another reason why it's probably not a good thing to use an alternate regimen, because you have to bring the patient back for a test of cure. If you use first-line ceftriaxone with either azithro or doxycycline, you do not need to bring the patient back for a test of cure. If you use an alternate regimen, you need to bring them back for a test of cure about 1 to 2 weeks after treatment to make sure that they responded to therapy. If they failed therapy and you've ruled out reinfection, remember, many of them can get reinfected. That's not really a treatment failure, that's just reinfection. But if you suspect treatment failure and you've ruled out reinfection and they were treated with an alternate regimen, then now you have to use ceftriaxone plus 2 grams of azithromycin, not 1 gram of azithromycin. If for any reason you suspect that a patient has failed therapy with a ceftriaxone-based regimen, and right now we have not detected ceftriaxone resistance in this country, but it has been detected in Western Europe and Far East Asia, so it's only a matter of time. If you suspect that they have ceftriaxone resistance, 1, make sure you culture and send the culture to document that. 2, contact your local health department immediately or the CDC. And 3, contact an ID specialist who can help you figure out what you need to use to treat your patient. And I'll show you a few options coming up in a few slides. What if you have a patient who comes in and says, I have a penicillin allergy? What should you do? Remember that the cross-sensitivity between penicillin and cephalosporins is very low. And the risk for cross-sensitivity between penicillin and cephalosporins is highest with first-generation cephalosporins. Remember, to treat gonorrhea, we're using third-generation cephalosporins. So if a patient comes in and says, I have a penicillin allergy, what I usually tell them and ask them is, okay, have you ever taken Augmentin before? Remember, Augmentin is a penicillin. It's amoxicillin. And if they say, yes, I've taken Augmentin, I give them ceftriaxone. If they say, no, I have never taken Augmentin, the next question I ask is, okay, have you ever taken a cephalosporin? And usually I'll say Keflex. Have you ever taken Keflex before? Most people have taken Keflex. If they say, yes, I've taken Keflex, I give them ceftriaxone. If they say, no, I've never taken a cephalosporin or a penicillin, I ask them, of course, about the type of allergy. If it was a serious allergy, IgE-mediated allergy, they couldn't breathe, they developed hives with penicillin. In that case, I would use 2 grams of azithromycin to treat them. If it's a mild allergy with penicillin, a rash, etc., you can use ceftriaxone to treat them for gonorrhea. So remember, if they say penicillin allergy, ask about the type of allergy. If it's not serious, you can use ceftriaxone. If it's serious, ask them about Augmentin and about other cephalosporins. And in most cases, you'll be able to use ceftriaxone in these patients safely. Future antimicrobial options, there was a recent randomized trial that was conducted by the CDC. It was presented in abstract form, and it will be published in Clinical Infectious Diseases in the next few months, where they used alternate regimens to treat patients for gonorrhea. And these regimens included azithromycin and gentamicin, and gemifloxacin with oral azithromycin. None of these options are great. Gentamicin has to be given IM, and usually you have to give 2 or 3 doses of it to get to 5 milligrams per kilogram. So none of the options are great. And in cases where you suspect treatment failure and ceftriaxone resistance, call your infectious diseases physician to get some input, or your local health department to get some input about what to use to treat your patient. I again remind you that most cases that you think are ceftriaxone failure will ultimately turn out to be reinfection. So keep that in mind. Reinfection is much more likely than failure, but if you suspect failure, make sure you send cultures to document it, and make sure you call your local health department. And we talked about this. And this is a very important slide. It is critical that all STDs, gonorrhea, chlamydia, and HIV be reported to your health department in a timely manner. And make sure that when you're reporting your HIV cases, you're filling out the forms completely to help the folks in public health track these patients. So remember, timely and complete reporting. It is the law, and we have a link on the slide to essentially help you if you live in the state of Maryland. If you don't, if you live in another state, then go to your local health department website. I'm sure you will find the appropriate links to report these patients. Case 3, we're almost done. A 32-year-old HIV-infected gay man presents for a routine follow-up appointment. He's doing well on his ART regimen. He has a history of several sexually transmitted infections. He's been monogamous with his current partner for the last 3 months. A sample is obtained for anorectal cytology, that is, an anal pap smear was done, and the results demonstrates ascus. Which of the following interventions is most appropriate at this time? Perform HPV type-specific testing, repeat cytology in 3 to 6 months, repeat cytology in 1 year, or refer for high-resolution anoscopy. So you've done a pap, you got ascus, what should you do? And the answer is, you get a second, refer for high-resolution anoscopy. So let me tell you, the HIV-MA IDSA guidelines that I'm following now are the first, to my knowledge, the first national guidelines to suggest anal pap smears in some of your high-risk patients. And so what do the guidelines say? They say in MSM, women with a history of receptive anal intercourse or abnormal cervical pap smears, and all HIV-infected persons with genital warts should have anal pap tests. But note here that this is a weak recommendation because the data are not very strong. If you're planning on doing anal pap smears, you must have a way to act on those results. In other words, you must be able to refer a patient for high-resolution anoscopy if the anal pap comes back abnormal in any way. If you don't have somebody locally that you can refer your patient to for high-resolution anoscopy, you should not be doing an anal pap smear. So only consider an anal pap smear in your high-risk patients if you have the option of referring them for high-resolution anoscopy. If you don't have people who do high-resolution anoscopy in your community, don't do anal pap smears. Remember, too, that HPV vaccination is recommended for all your HIV-infected men up to the age of 25 and women up to the age of 26. Even if they're HIV-infected, the recommendation is to give them the vaccine series, 3 vaccines, 0, 2, and 6 months. You can use the bivalent vaccine for women or the quadrivalent vaccine for both men and women. Remember, the quadrivalent vaccine is the only one that protects you against genital warts, and it's the only one that's approved for use in men. Remember to vaccinate your HIV-infected men and women for the HPV. Last case. A 30-year-old HIV-infected man presents with a rash covering his abdomen and proximal extremities, and he has low-grade fevers. He denies headaches, and his neurological exam is normal. His RPR is reactive at a titer of 1 to 2,056, and his FDA treponema test is reactive. Which of the following treatment regimens is most appropriate? 2 grams of azithro, 100 doxycycline twice a day for 14 days, benzathine penicillin 2.4 million units, or 3 doses of benzathine penicillin 2.4 million units. 1 second. All right, my friends, your time is up. And the answer is 1 dose of 2.4 million units of benzathine penicillin. So this patient has early secondary syphilis. This patient has classic secondary syphilis. The good news is you've done a good neurological exam. You've asked him about any neurological symptoms, and you've done a good neurological exam. So you've ruled out the possibility of early neurosyphilis. Remember, in HIV-infected persons, they're at higher risk of having early neurosyphilis, which occurs within the first year after being exposed to syphilis. And usually these patients will present with a headache. Sometimes they'll present with a stiff neck, cranial nerve abnormalities, rarely with a stroke. So any HIV-infected patient that you see in your clinic and you diagnose syphilis, you must do a good neurological exam to make sure they don't have neurological involvement. In this case, there was no evidence of any neurological involvement. The great news is, with your HIV-infected patients, you treat them exactly the same way as your HIV-uninfected patients. In this case, he has secondary syphilis. You only need to use 1 dose of 2.4 million units of benzathine penicillin. There are no data to suggest better enhanced efficacy of 3 doses. Never, ever use azithromycin to treat your HIV-positive MSM because there is drug resistance. There is resistance of the Treponema pallidum to azithromycin. And in this city, in Baltimore, about 30% of Treponema pallidum are resistant to azithromycin. So the recommendation from the CDC is not to use azithromycin in MSM and HIV-positive persons. If a patient has a true penicillin allergy, your only other option is to use doxycycline. So in this case, the patient does not have a penicillin allergy. The best drug to use is long-acting benzathine penicillin G, 2.4 million units. And the patient, we did a good neurological exam, and the patient does not have any neurological symptoms. A recent observational study was done that compared 1 dose versus 3 doses of benzathine penicillin, and they found no benefit to the use of 3 doses of benzathine penicillin for syphilis. So, ladies and gentlemen, we've covered screening in our HIV-positive patients. We've talked about the importance of getting a good history and asking the right questions in the right way. We've talked about screening for gonorrhea, chlamydia, syphilis, trichomoniasis, and herpes in certain situations. We've talked about the management of gonorrhea and the risks of drug resistance. And we've talked about anal pap smears, when to do them and when not to do them. And finally, we talked about the appropriate management of syphilis in your HIV-infected patient. The next 2 slides have resources that you can use if you live in Maryland. These are some very useful resources. And if you live outside of Maryland, these are some also very useful resources. Please remember, if you have any questions, email your questions or click on the link online. Thank you very much for your attention.